to be cognizant of everyone's time. Perhaps I'll get started as people continue to come in. I'd like to welcome you all to this Alberta Transplant Institute seminar on October 22nd. My name is Darlene Jaguzik. I am the program manager at Canadian Blood Services for the Kidney Paired Donation and Highly Sensitized Patient Programs, and I will be your moderator today. I'd like to start with a brief land acknowledgement and let you all know that we acknowledge that the University of Alberta is located on Treaty 6 territory and respects the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. I would also like to start with a thank you to Astellas for their generous support of the ATI seminar series. And then to get started, I'm very excited to introduce our speaker today. Dr. Rahul Mainra is a transplant nephrologist at the Saskatchewan Transplant Program. He is a professor of medicine and director of faculty and clinical placements of the Master of Physician Assistant Studies program at the University of Saskatchewan. He completed medical school and internal medicine residency training here at the University of Saskatchewan. He did his internal medicine residency training, fellowship at the Western University in London, and advanced transplant training in Sydney, Australia. He is currently chair of the Willing to Cross Working Group for Canadian Blood Services and a board member of the Canadian Society of Transplantation. So before I turn it over to Dr. Mainra and welcome him today, I will just ask that you save any questions for the last 15 to 20 minutes of the seminar, or you can place them in the chat as we go along. So with that, Dr. Mainra, I will turn it over to you. Welcome.
Thank you very much and welcome everybody. Good afternoon. Happy hump day, I think. Is that what they say for Wednesdays? I'm just going to get my screen going here. Hopefully you can see that okay.
Yeah, perfect.
Awesome, great. Well, thank you very much to the organizers and to the Alberta Transplant Institute for inviting me to give this talk. Very passionate about the Willing to Cross program and the opportunities for our patients. Not sure why my slides are not advancing. There we go. So I have nothing to declare. I have no conflict of interest that are relevant to today's talk. And you've seen the objectives already today, but hopefully by the end of today's talk, you'll be able to describe the type of patients, the phenotype of patients that are in need of Willing to Cross and in need of a Willing to Cross program. We'll briefly review the literature on HLA incompatible kidney transplant, and then we'll go into the real specifics and the criteria and management of the Willing to Cross program in Canada. And we'll talk about limitations and the potential future of the program. And I present this on behalf of our working group. Many of the members are on this picture here. Some of them have moved on to greater things and have been replaced by other members of the working group. In the end, none of those people that have retired they're all irreplaceable. But the importance of our working group was to get the professionals together to ensure that we develop a program that can be supported nationally. We needed to ensure that everybody would get behind this program, everybody would get behind the protocol that we developed. And I'm not going to say that it was easy. These are all very intelligent people, and I think we did an amazing job of bringing everybody's opinions together, getting the lay of the land to understand the nuances of every program across the country and every jurisdiction and their limitations on what they have access to with respect to therapeutics for their transplant patients. And I sort of compare it to, I'll use this slide here. This is a team that I'm sure many of you know a lot about, but you can see here there's 4 members of the Edmonton Oilers. They're all from Canada. They're all have different positions on the Edmonton Oilers. And And we can't really compare each team. We can't tell Skinner to score more goals. We can't tell McDavid to do a better job between the pipes. But in the end, their main goal is to win the Stanley Cup. And I think we need to, our program is very similar. We have one goal, which is to win the Stanley Cup for our patients, which is to have a successful and safe transplant. But we need to make sure that across the country, we're all doing the same thing, that we're all using the same metrics, the same protocols, so we know that what we're doing is safe and successful. The Edmonton Oilers, yes, I'm sure all of you are very passionate about, but ultimately the true and best team of the NHL, and always will be the best team of the NHL, is the Montreal Canadiens. Anyways, there's my plug. Another great team that's been inherently part of this program and many programs for our patients is Canadian Blood Services. Their assistance and their support for interprovincial organ sharing for kidneys specifically, and all the projects that have stemmed from KPD, from the kidney pair donation and the highly sensitized patient registry has been incredible. So thank you to them. I thought I'd just go over some of my abbreviations and some slang I might be using, just so we are all on the same page today. You've already heard me say IPOS or IPOS, interprovincial organ sharing. That's the sharing of organs. I'll be talking primarily about kidneys across the country. CPRA or PRA is the calculated panel reactive antibody test, which is basically just a probability of how likelihood of a patient receiving a compatible transplant. And the important thing to remember, especially for Willing to Cross, is once an antibody, always an antibody. So if a patient has an antibody that showed up 7 years ago, that antibody, and it's never been seen since, that antibody is always going to be on their panel. And we'll talk about sort of the nuances of that later on. HSP is our highly sensitized patients. Those are the ones with PRAs of greater than 95%. And I like to call the PRA 99 to 100% population the very highly sensitized patient core of the Canadian Organ Replacement Registry. DSA will be talking a lot about that. Donor-specific antibody. Crossmatch is our XM, performed either by flow crossmatch or CDC. ATG, thymoglobulin, which is one of our induction agents, and AMR, antibody-mediated rejection. So to start off, just to highlight the success of kidney interprovincial organ sharing, the first program, the kidney pair donation program, which was started back in 2009, and it was initiated to help recipients who have an incompatible living donor find a transplant. So this program since 2009 has resulted in almost 1,200 transplants. And these are 1,200 transplants that would not have happened without the KPD program. And as you can see here, the majority of them, so almost 90% of them, have been unsensitized, that meaning 0 to 95% PRA. But 10%, approximately 10%, have been highly sensitized patients with PRAs greater than 95, and almost half, or 4.3%, have been the very highly sensitized patient population. But if you look at the actual the KPD pool of recipients that are waiting for transplant or within the registry at any one point in time, you can see that the HSP population in the gray, purple, and the two reds makes up far more than 10%. And over time, it's made up about a half to a third of the overall KPD pool. So you can see that there's a lot of patients that are very highly sensitized that are still waiting to be transplanted within the kidney pair donation program. Similarly, another great IPOS program managed by CBS is the Highly Sensitized Patient Registry. This started in 2013 and became a national program in 2014. And since its inception, it has resulted in over 1,100 successful transplants. And these are transplants for patients that are the hardest to match. And we've done this by sharing one of our deceased donor kidneys into this registry, and we've shipped that kidney across the country to allow for one of these transplants to happen. And as you can see, once again, we've been very successful with getting our very highly sensitized patients transplanted. You can see that almost half, if not over half of them have had PRAs 99 to 100%. So that's been a huge success. However, when we look at the overall pool of patients that are waiting, once again, similar to the KPD registry, the mass bulk of patients that are waiting for transplant within the highly sensitized patient registry have PRAs of 99 or 100%. That's the two red ones. So it definitely is very challenging for those patients to find a compatible transplant, even when we've expanded access to be from coast to coast to coast. So the reason we need a Willing to Cross program is to help those patients. So you can see here in this bar graph, the yellow bars are the ones that have been transplanted already. The red are the ones that are still on the wait list across various PRAs, 95 up to 100. And we do a really good job of getting patients with PRAs of 95, 96, 97, 98, even somewhat into the 99, getting them a transplant through the HSP registry. When we have a patient with a PRA of 100, the proportion of patients that are getting transplanted is very low. And this is why we need another program for these patients. And just to highlight just a little nuance of the reporting here. So these are PRAs that are rounded up to 99. So there's no decimal places. So that means that this bar of 99 is anybody with a PRA from 98.5 to 99.4. And I'm sure all of you can recognize and understand that patients with a PRA of 98.5 are very different than a PRA of 99.4. So just keep that in mind when I show you some of this data, and this will become very important as we get into the eligibility of the Willing to Cross program. And sorry, I'm looking over here. You probably can see that I've got another screen, and that's where my next slide little button is. So please forgive me for that. The other reason why we need a Willing to Cross program is because a lot of these patients are waiting in the registry for a long time. You can see here as the PRA goes up, they're in the registry for months to years at a time. And all of you can appreciate that the longer our patients stay on dialysis, the higher their risk of dying, or the higher their risk of being permanently removed from the wait list increases. So we really need to get these folks transplanted. We've been very successful in both of these programs. This is the graft outcomes, long-term graft outcomes, looking out to 10 years. So the top graph there is the KPD program. You can see that 10-year graft survival of 74%, which is at the core graft survival benchmark. And the bottom curve, so that's living donor kidney transplant, remember, and then the bottom curve here is the HSP registry, which is deceased donation, where our 10-year graft survival is actually better than the core benchmark. And overall, we've had a fairly acceptable number of rejections in both of these programs. So this is data going up to 10 years, and a lot of this is some of it is unknown types of rejection. Some of it is there's no biopsy reported. So the data is the data. But overall, in those 10 years, we've got a rejection rate of about 13% overall, with very few antibody-mediated rejections, only about 2.4%. And naturally, with the HSP registry, with these patients being more sensitized, the rejection rate is a little bit higher, not excessively higher, at about 15%, with a little bit higher rate of AMR of about 3% of the total population. So these programs have been very successful. So Dr. Trish Campbell, which I'm sure many of you know, we looked at some data. This was just after the COVID pandemic. We received data on over 1,500 patients within the HSP registry, of which about 376 of them had been transplanted. And what we wanted to do was look at the data in a little bit more granular fashion. We wanted to ensure before we embark on Willing to Cross, is the program running successfully? Is it running safely? And are we setting ourselves up for success? Are we going to be doing a good thing for our patients? So what we did was we wanted to look at the two different categories of PRAs. So 99 to 100, those would be eligible for Willing to Cross, and 95 to 98. And as you can see, as I've shown you before, the number of patients that are transplanted in the 95 to 98% category is almost 2/3 of the ones that are waiting. And that's almost the complete opposite of the ones that are 99 to 100, which is less than a third of those patients have received a transplant. Age is fairly similar, mainly female predominance, which we would expect given their sensitizing events. And as we've seen earlier, the days in the registry, whether they're transplanted or waitlisted, is significantly higher for those that have a PRA of 99 to 100%. The interesting part of this was that looking at the number of offers that patients received before they actually received a transplant. And I think we can all appreciate this. We know that the HSP registry is very successful for patients with a PRA of 95, 96, 97, even 98. So we'll very commonly turn down an offer knowing that another offer is going to be just around the corner. And that's what the data showed, is that on average, it took 2.5 offers before those patients were transplanted. But even those that are very highly sensitized, with PRAs of 99 to 100%, had an average number of offers of 2.1 before they were transplanted. And what I think is more striking are the ones that are still waiting for transplant. You can see that about 22% of the patients that are very highly sensitized have actually received an offer that was declined on their behalf. When we look at overall death-censored graft survival and all-cause graft survival, looking at these two PRA categories, they're overall, with 7-year follow-up, very similar. So the data shows us that these patients are doing well. Even if we look from a granular perspective, look at the specific patients that are very highly sensitized, those patients have very good outcomes, and it would be very reasonable to proceed with a Willing to Cross program for the patients that need it. So just going through a little bit of the literature that is present for HLA incompatible transplants. These studies were probably the first ones to publish their history and their results on HLA incompatible transplants. These are all living donor transplants. The first study was in 2016 by Dori Segev in the US, and the second study by Yang from Korea about 5 years later. These are not very similar to the protocol that we'll be talking about for Willing to Cross. They all received pre-transplant desensitization. So they all received rituximab, plasmapheresis, intravenous immune globulin. But what I wanted to highlight from this study is that overall, if you received an HLA incompatible transplant from a living donor, it was better than waiting for a compatible transplant from a deceased donor, and significantly better, as we can imagine, than if you didn't receive a transplant and you're still waiting on dialysis. So this sort of led the way and suggested, in the setting of desensitization, if that was your thing, then proceeding with desensitization in the living donor incompatible transplant was a fairly good option. Moving a little bit closer to our program and our protocol, these studies did not use desensitization protocols. They were once again incompatible living donor kidney transplants, so only live donors. The induction agents that was used in the Santos study was either alemtuzumab, daclizumab, or basiliximab. They also actually used a steroid-free protocol, whereas the Abbas study used thymoglobulin, which will be, as you'll see, a little bit closer to what we're doing here in Canada. Overall, graft survival between the incompatible living donor transplants compared to a compatible deceased donor transplant was fairly similar. However, when you look at rejection rates, and this is antibody-mediated rejection in the Santos study, there definitely was a higher proportion of patients that had rejection in the incompatible transplant. And I suspect these were steroid-free patients. Their induction immunosuppression wasn't as potent as the Abbas studied, which in their results, they showed no difference between DSA positive or DSA negative patients with respect to AMR. Another study, and I'm not going to focus too much on this study, but I wanted to highlight this one category of DSA positive cross-match negative, which, as we'll see in a little bit, is going to be very similar to our study. So this was a retrospective study looking at a number of patients with known donor-specific antibodies pre-transplant with sort of a varying degree of risk. So the cross-match negative and then a varying degree of positive cross-match. And just to be clear, there are some patients here, specifically in the ones that had a very strongly positive flow cross-match for B cells that did receive desensitization. Induction was primarily ATG or basiliximab for those that didn't have any DSAs. Overall graft survival was fairly similar. You did start to see sort of poor outcomes in those that are the highest risk, those with DSA positive plus a very strongly positive B cell crossmatch, where their death-censored allograft survival and risk of chronic AMR or acute AMR was definitely higher than some of the other categories. But I wanted to highlight this group, which is the DSA positive cross-match negative, which will be very similar to our patients coming into our program. And when you look at the numbers of acute antibody-mediated rejection or chronic antibody-mediated rejection, we're looking at about no more than 20%, so 15 to 20% out to about 5 years, which is very acceptable for this high-risk group of patients. One last study that I'll bore you with, once again, these are deceased donor transplants primarily. Once again, no desensitization, and all of them were DSA positive flow cross-match negative patients, and there was about 162 of them. About 70% of them received thymoglobulin induction. Once again, not a lot of people that were highly sensitized, so 80 to 100 PRA was only about 16% of the population. Their acute rejection rates at 1 year was overall fairly low. The rates of antibody-mediated rejection was higher than those that are DSA negative, but still only 3.7% at 1 year. When we look at death-censored graft survival, so this is comparing the DSA positive patients to those that are highly sensitized but have no DSAs, overall graft survival out to 5 years was the same. There were a couple of signals about risk of antibody-mediated rejection or acute rejection that seemed to be higher, although not statistically significant in that top middle bar graph there. If your MFI, cumulative MFI was greater than 3,000. But then if you look down in the lower right-hand side there, the risk of acute rejection at 1 year was higher if those DSAs didn't go away. So if you had DSAs pre-transplant and they stayed around post-transplant, those are the patients that had a higher risk of acute rejection. Overall graft function measured by GFR and proteinuria were fairly similar amongst all the groups. So what can we conclude from all of these studies? We can tell that transplantation with an incompatible transplant is better than waiting for one on the wait list. There doesn't seem to be a lot of difference in graft function, whether that be GFR or proteinuria, but there are some signals that predict a higher risk of AMR, chronic AMR, graft failure, and those would include a high MFI, high positivity flow crossmatch, and high PRA. none of these studies are still perfectly generalizable to our patients and our protocol that we have developed. So without further ado, let's talk more about our program and the protocol. So eligible patients for Willing to Cross within Canada um, need to be enrolled in either the HSP registry or the Kidney Pair Donation Program registry. They need to have an unadjusted CPRA of at least 99.0%. So now we're throwing in that decimal place. So we don't want 89.5, 89.6, or sorry, 98.5, 98.6. We want 99.0% patients in the registry for Willing to Cross. And after we adjust them, after we remove some of those antigens, their PRA must stay above 95%, at least for the HSP program. If it falls below 95, then they'll lose the benefit of being within the HSP program. This is a higher risk transplant, so the recipients need to be well. There needs to be no underlying contraindication to undergo a high risk transplant. A couple of other points to make before we get too far ahead is delisting of antigens is up to the local program. There is assistance from our Willing to Cross working group and the National HLA Advisory Committee that can assist each local program, but we've left it up to the local program as to which antigens should be delisted. And they must all have a negative flow cross-match prior to going to the operating theater for surgery. So we needed, as I mentioned earlier, we needed to have a standardized protocol, how we manage patients, whether that be induction immunosuppression. As you can see here, it's thymoglobulin based with our standard triple therapy with tacrolimus. We needed to have standard maintenance therapies. We needed to make sure that everybody is going to be on steroids. Tacro levels of 8 to 12 within the first month and going down to 6 to 8 by month 6. We wanted to have standardized treatment of rejection. So this is how you would treat antibody-mediated rejection based on the current evidence. The evidence for treatment of AMR is not great. And this is what we felt as the working group was the best standard of therapy at this moment in time, which consisted of methylprednisone, plasmapheresis, and intravenous immune globulin. We defined resistant or ongoing antibody-mediated rejection as that which persists where the creatinine doesn't return to baseline within 2 to 4 weeks following completion of treatment. So sometimes this therapy itself will take 2 weeks. So if the creatinine doesn't improve within 4 weeks after that, then we would recommend another biopsy to find out what's going on. Are you still seeing some acute lesions? And then basically do what you think is best within your local program. We've given examples of rituximab, bortezomib, ongoing plasmapheresis, IVIG, but ultimately the evidence in this patient category is not all that robust. And of course, our working group is available for consultation if necessary. We need to have outcome monitoring. We need to ensure that this program is safe for our patients and successful, and we can't do that without data. I've got the word mandatory. It's strongly encouraged. Nothing is mandatory. Nothing is forced upon people, but the success of this program is up to us when we submit this data. So this is none of this is really profound. We do want a number of DSAs monitored. We wanted them monitored early to sort of catch the memory response and the peak in DSA that can happen early on post-transplant, and then monthly up to, or 1, 3, and 6, and then 12 months, and then yearly thereafter. These are all patients that are getting fairly robust immunosuppression, so we wanted to know if there's any infectious complications like BK viremia. We need a protocol biopsy done on all of our patients, and this is because there is a high, I don't want to say high, but there is a number of patients that will have subclinical AMR. So we want to make sure that we catch that. So we've incorporated a protocol biopsy as part of the standard protocol. Indication biopsy, we've provided reasons as to when to perform an indication biopsy, development of a new DSA, recurrence of a historical DSA that was not present at the time of transplant, or a significant increase in DSA, and that would be in consultation with your HLA lab. And if the GFR is kind of dodgy, if it's less than 20 mils per minute at 6 weeks post-transplant, you don't have a good idea as to why that is, you haven't done a biopsy in a few weeks, it's a good idea to do a biopsy at that time. We would ask for that to ensure that there is no rejection at the time that can improve the overall GFR. And DGF as your clinical standard, as your center standard, and any other clinical indication. We need to know about biopsy-proven AMRs, TCMRs. We want to know when the graft fails and why. We want to know when a patient dies. And we also want to know if you've accepted a transplant through the HSP registry, but for whatever reason, it goes into an unintended recipient. We've put in a number of automatic safety triggers, and these safety triggers will make us halt the program very temporarily, but halt it, to allow the working group to have a look at what's happened, to have a look at the protocol, and see if there's anything that needs to be, if we need to pivot, what else we can do to mitigate that risk. And some of those safety triggers are the number of AMR. So I don't think any of the studies that I showed you had this high of an incidence of AMR, so I don't think we're going to reach this, but we felt that a 30% incidence of AMR is unacceptable, and we would need to review the program. Within the HSP registry, we don't want programs to be bringing in kidneys and not giving them to your willing to cross patients. So we said if this happens more than 10% of the time, then we need to halt, and we need to figure out ways to mitigate that and to improve the logistics of that process. And CBS has worked very hard with the ODOs and the OPOs across the country. And there's an agreement that in the case of a willing to cross transplant or a willing to cross match, there will be some blood, hopefully, shipped from the donor program to the recipient site in advance of the kidney being sent, so that the recipient site can do their cross match and ensure that it is negative. Patient death within 6 months will cause us a halt. Early graft failure within 3 months, secondary to rejection, and primary non-function secondary to antibody-mediated rejection would be reasons for us to halt the program and review and see what we can do to do better. So we know this isn't a perfect program. We know that there's limitations to the program. We had to start somewhere. We had to start with a base structure. We had to start with a structure that was going to be acceptable to the entire country. So did we get it right? I think there's definitely some limitations for us to discuss. One of them is a negative flow cross-match realistic? Can we, when we're crossing a number of DSAs, are we going to run into the possibility of a positive flow cross-match and leading to a large number of kidneys being imported and transplanted to other patients? This study looked at this very nicely. So this was a Brazilian study with collaboration with Dr. Lusky and in the lab in Halifax, and they looked at that very question. So they looked at what level of MFI, when you look at each of these HLA genes, would you expect a positive flow cross-match? So if you look at HLA-A, when your cumulative MFI is at about 3,000, almost 100% of those samples had a positive flow cross-match. For HLA-B, it was 5,000. For HLA-DR, also 5,000. And for HLA-DQ, 15,000. So there's a very likelihood that as we cross more of these antigens, as that MFI starts to hit some of these numbers, there is a likelihood or a possibility that the flow cross-match will be positive. And if we've already imported the organ, that will be transplanted to an unintended recipient. The next question is, should we have a clear delisting strategy? We've left that up to the local programs to do. You guys know your patients the best. You know the history of your antibodies that have shown up over time. We felt that this was the best procedure to utilize. However, there is a really elegant study that looked at a clear delisting strategy, and that's up in the right-hand side there. They had 3 different categories: a low risk level, medium risk level, and high risk level. And patients who they all started off at the low level. They tried to get a transplant. If they weren't transplanted within anywhere from 6 to 12 months, then they would move up to the next level. This was a retrospective study of 53 truly highly sensitized patients, so patients with high PRAs of 95 and above. It was not desensitization. Primarily, they all received thymoglobulin. There was almost a third of them that also received rituximab in addition, and this was up to the local nephrologist who was transplanting that patient. Generally, this was for the patients that were at the medium and high risk level. And they were successful. The PRA went down from 99.7% with their delisting strategy to 98.1%. And that resulted in patients being transplanted within an average of 7.2 months. So it worked. The overall rejection rates were not crazy. There was 12% acute AMR compared to 4% in your HSP DSA negative population, and compared that to 2% in the non-sensitized population. And these episodes of AMR were primarily all in the medium and high risk level, and also when some of the MFI was mainly was greater than 5,000. Overall graft survival, the top dashed line there is your non-sensitized patients, and then the 2 other lines are your DSA positive patients, the ones that had crossed antibodies, and then your DSA negative patients. And there was really no difference in graft survival or patient survival up to 5 years. So this study showed quite nicely that a delisting strategy could be very beneficial. Is the risk low enough, or perhaps it's too low? And I think our working group, we tried our hardest to come up with a protocol that's going to minimize this risk as much as possible. And if we think about what risks are we talking about graft failure, rejection, I think regardless, the protocol that we put forth based on the current literature, we felt was the best for starting this program. We are very committed after 6 months, after 12 months, to look at the data, look at our transplants, and see if we need to pivot, see if we can start taking higher risks. And that would be, once again, as the previous study looked at, do we now look at different antigens or antibodies for us to cross? And time will only tell. As we do more transplants, we'll learn whether or not our risk level is appropriate. So the finish line for our patients obviously is for transplantation. For us as clinicians, we want to have a safe and successful program where we're getting our patients off dialysis and getting them willing to cross transplant. So let's look at that, and maybe I should have put a different trophy up on this slide given the recent success of the Blue Jays. So what has our program done so far? So we currently have actively waiting on the Willing to Cross registry, 28 patients. 23 of them are waiting in the HSP registry, and 5 of them are in the KPD registry. We've had one proposed match in one of our KPD cycles that for a patient with Willing to Cross. There have been 17 offers through HSP for our patients, and overall 3 transplants so far since we've started. The first one, which is in May of 2025, soon after we went live with our program. This was at St. Paul's Hospital. They were able to get the PRA down from 100% down to 95.2%. So you can see they needed to stay above that 95% to be within the HSP program. This was that patient's second Willing to Cross offer, and they've done quite well. The donor center was from Ontario. We did 2 transplants this month, one in London. This was their first offer. The PRA went down from 100% only by 0.1%, but that 0.1% was enough for them to get an offer through Willing to Cross. The other transplant was once again in St. Paul's Hospital in BC, and their PRA came down by 0.3%. And this was actually the fourth offer for that patient. So even a small difference in PRA led to multiple offers for that patient. So this is all good news. And what I've heard from the clinicians involved is so far all 3 of these patients are doing very well. But it's still very early. We've only done 3 transplants. We still need to see the future successes of this program. So in summary, hopefully I was able to discuss and describe the type of patients that need this program and need Willing to Cross to get a successful transplant. We talked a little bit about the literature around HLA incompatible transplantation. We talked about the eligibility and the protocol and the management of our Canadian Willing to Cross program. And we also talked about the limitations and perhaps the future of where the Willing to Cross program will be in the next few years. So thank you very much for your attention. I'm happy to take any questions or hear people's comments. And I'll stop sharing my slides.
Thank you so much, Dr. Mainra, for that, for sharing the incredible work and a really great, engaging presentation. Perhaps, I don't see any questions in the chat, but perhaps while we're waiting for those to raise their hand, I was wondering if you might be willing to share some personal insights. So, for example, how do you engage with patients in a shared decision-making conversation when offering a donor with DSAs to them?
Yeah, so that's a great question, and BC's done a lot of work on the consent process, because we do need to get we need to have those discussions with our patients outside of the middle of the night when we offer them those organs. We need to have that discussion with them in the clinic setting in a low sort of stressful situation. This program does require added testing. It does require a biopsy at 3 months. So our patients do need to consent to that. So BC is put together, which is available for everybody to use, a consent process for us to discuss with our patients. And I think a lot of our patients that are in need of Willing to Cross have been waiting for years. And they know that something else has to happen for them to get a transplant or an opportunity for transplant. So I think they're all looking forward to this. They understand the risks, and I think the important aspect is that this is just another tool for us to try to expand that access. With the potential for risks, right? There's risks of rejection. We know that. It's real. But
Excellent. And just a question in the chat from Sim that kind of piggybacks nicely off that. He or she is asking, how do we determine if a person is eligible for Willing to Cross within a program?
So that would be based on your HLA lab providing you with your PRAs of your patient population of your wait list. And anybody with a PRA of 99.0% and above would be at least that first tier eligible. I can provide you with our experience in Saskatchewan. We've had a few. I think we have about 10 or 12 patients that have PRAs of 99.0 and above. we've had a few patients that have been in the waiting for a long period of time where we've been able to have a fairly lengthy number of their antibodies for us to review and to say, well, these are historical antibodies. We haven't seen them for a while. Let's cross them, and we can see what happens to their PRA. Some of them have just been listed. So we don't have a long enough period of time where we've got their antibody profiles to confidently say, you know, this antibody isn't very important. Let's cross it. So it is a lot of work for our HLA colleagues. They have to go through every antibody, go through the history of it, and see whether or not it would be safe to proceed to crossing that, and then play around with the calculator to see, is it gone down too much? Is it below 95%? How do I get it back up to 95%? So that would be sort of how you would determine at least the start of getting those patients into willing to cross.
Excellent. Thank you. And Trish, I see your hand raised. I believe you were next if you'd like to unmute.
Thanks, Rahul. Thanks for that great overview. And I'm so happy to see this program is now finally live. Just a couple of comments historically, and things may well have changed since I've been away from the program. But I think, you know, your points about the cross-match eligibility, everything are really something that historically, when we started the whole HSP program, there's a lot of unwillingness in the country to share organs. And you may remember, I think you were involved in some of those early discussions. And so initially, the decision was that there would only be 50 kidneys shared nationally in any shared registry. That was what was agreed upon between the Kidney Working Group, the KTAC group, and KDPE. And then as things evolved and we realized when we got it up and running and it was successful, that we had probably set our threshold of what we were calling antibodies and not willing to cross higher than we needed to do to get successful transplants, which is when we started to push for the Willing to Cross program a number of years ago. There was a lot of pushback again between the Kidney Working Group and KTAC and the HLA group is to try to find that balance between risk versus benefit. And even more remote recently, I recall when we sort of looked at when to call an antibody historical, it was often the kidney group that was the most conservative about what should be done. And I think with the national registry, it's tough because, you know, we want each program to be able to do its own thing, but at the same time, it is a shared organ process. Where is all that now? Does everybody feel that we need to be more open to crossing more antibodies? I mean, I know each program doesn't have to list them if they're not comfortable doing it, but they are involved with shipping organs and sharing things.
Yeah, that's a great question, Trish, and definitely very important, and especially coming from you. I think um, it's I think as you can see, with only 28 people, patients across the country that are willing to cross, I think there's lots of programs and lots of provinces that, for whatever reason, are unable to get patients into the Willing to Cross program. And I think we talk about this at our working group meetings. We discuss what do we need to do, and my colleagues always tell me to be patient. Let's just wait, give it a few more months. Let's see what happens. So I think I think time will tell, Trish. I think we need to see if we can get more patients within the Willing to Cross program. If we can't, if right now the majority of those patients are from 2 centers across the country. So we need to make sure that we are hearing from everybody as to what their barriers are, and how can we make it easier and how can we make it better. I think the success of HSP has really brought out the generosity of programs and ODOs. I think we've all seen a lot of our patients get transplanted. We've seen some very difficult patients with with very high PRAs getting transplants. And I think that has really put to the side those concerns that were around very early on when we felt that we could only share a certain number of organs across the country. So that's been very positive, but I think we still have some work to do yet. I think in this program, I think we still need to investigate and listen to programs as to what are the barriers, why are you not able to get more patients into the registry before we can say that we've been successful.
And it's just a current cross-match negative you need, right?
Yeah.
Correctly. Yeah. Okay.
Yeah.
Thanks.
Excellent. Great question, Trish. Thank you. Dr. Mainra, next we have Catherine, and she is asking if there are any special considerations for pediatric patients within the context of Willing to Cross.
That's a great question. I mean, I'm not a pediatric nephrologist in full disclosure, so I don't think so. I mean, we have some other great programs for our pediatric patients. We have within the HSP registry or within the national sharing of organs, we are sharing 0 class 2 mismatched kidneys to those kids. And I think Darlene can correct me, but I think there's been a number of transplants across the country for these kids. So I would imagine that there's probably not a lot of kids that are going to come into Willing to Cross. I think that the ideal scenario for our pediatric kidney patients is to get a more compatible transplant as to a less compatible transplant. That being said, I'll be honest, I'm not aware and I don't know the literature around pediatric incompatible transplants for kidneys anyways.
Excellent, thank you. Lauren asks next, within the HSP program, are offers always made to the highest CPRA candidate first? What are the other factors that currently determine who is offered an organ first? And are you considering any future changes to how HSP allocation takes place?
Yeah, that's once again a great question. I did have a slide on the sort of the criteria for allocation. I didn't include it. But yes, and Darlene can definitely speak to this way more accurately than I can, and she'll keep an eye on that I'm not saying something inaccurate. But the highest CPRA candidates, so those patients that have a CPRA of 99 to 100%, that's unadjusted. So ultimately, we want a clean, compatible transplant for our HSP patients. So the very top of the list would be those that have an unadjusted CPRA of 99.0 to 90 or 99.5 to 100. And then if we don't match anybody in that category, then we start looking at the adjusted CPRA. And the adjusted is basically what is after Willing to Cross. So that PRA that comes down as a result of Willing to Cross. And then we look at that population and so on and so forth. And we sort of keep going down until we've exhausted the Willing to Cross patient population, which is 99.0 to 100. And then we include the rest of the HSP candidates, which is 95 to 99.0. Within that is going to be the medically urgent patients. There are patients out there that are highly sensitized that are medically urgent, so they would be preferred to get a match. And of course, there's other nuances to the algorithm. We want to try to keep kidneys within regions so they're not being sent across large, vast areas of our country to minimize the ischemic time. But Darlene, anything else to say on that, on the allocation?
I think the only thing to add would be if you've ever been a living donor,
Right.
if you've been a previous living donor, you do rank pretty close under that medical urgency as well. Otherwise, bang on. Great job. All right. Next, I think I see Esme, you have your hand raised. If you'd like to unmute and ask the question, that'd be great.
Yes, no, thanks. This was a great talk. And I don't really have a question. I just saw a comment, and I think you alluded to it, like how is it done like locally in Edmonton? And I thought maybe I'll just comment a little bit on that because there were a few patient partners on the call as well who probably, are curious how that works. At least here in Edmonton, I can't speak for Calgary, but in Edmonton, what we have done is we've made a list of all our patients who have a CPRA of 99% and greater. And while we're reviewing these patients, if these patients have antibodies that could be considered willing to cross, then we will bring this back to our renal program, to the renal team, and we have monthly listing rounds where we bring one or two cases forward to discuss. The renal program can also bring names forward as well if people are interested in finding out if they're eligible or not. Unfortunately, not everybody has willing to cross antibodies. That is another side of the story. And sometimes we also need to do some additional testing to kind of assess whether an antibody is truly gone, or, we try to do some surrogate cross matches, which is not always easy with highly sensitized patients, or we're trying to get some additional information. So there's a lot of, work done behind the scenes. But in Edmonton, we do review every patient now with the willing to cross in mind and see if they have any potential antibodies that could be crossed.
Great. Thank you very much for providing that information. It's very helpful.
Excellent. And another great question in the chat from Ahmed. He asks, what are the main concerns of patients and why might they be unwilling to participate in a willing to cross, preferring instead to remain on the wait list for anywhere from 5 to 10 years or longer?
Yeah, that's a fantastic question, and probably needs to be a nice qualitative study to look at that. And I'm not sure I can answer that entirely. I think that when and this is my personal opinion, I think we as physicians sometimes are, especially within transplantation, I think are a little too paternalistic. And I think we make decisions thinking that, oh, our patient is not going to want to do this. And we don't probably explain to every single one of our patients that are eligible for this program all the nuances and the risks and the benefits. And I think if we were to do that, I think we might find that more patients may be willing to proceed, because I totally agree with what you're saying. I mean, the outlook for some of these patients that have a PRA of 100.0% and they've been waiting for a very long time already, I don't think they're going to get a transplant until we do something to move that needle. So I don't know the answer to that, but I can only say that as physicians, I think we need to be very, we need to remove our own biases and our own opinions and approach every patient the same and say, this is a program and these are the risks, these are the benefits, and proceed with what their decision is.
Fine. Thank you so much, Dr. Mainra. We are at time, but I do have one more question. Would you be able to talk to that one question before we close today?
Is that from Dr. Halpin?
Yes.
Oh, okay.
Yeah.
And maybe so the question is, I'm curious to know if programs are including historic SERA in their cross matches.
I can kind of phrase it quickly too. Just I noticed that there does seem to be a little difference across the country of whether or not the peak serum, their most reactive serum, is included. It's not required, and I don't believe it's in the policy, but we're including it in Edmonton, but I'm not sure that it is universally. And does it matter, or is it distracting, or how do people feel about that? And did that ever come up in discussion when in the sort of policy discussion around how to do the test?
Yeah, I mean, I'll be honest. I mean, when it comes to the HLA stuff within our policy, we just ask the HLA experts on our working group and say, okay, what do you guys want to do? But I mean, I would imagine it would be very confusing if you're doing a historical cross match and perhaps in that historical serum was an antibody that you've actually crossed, then you're likely to get very likely to get a positive cross match. So I think, I mean, I think that the understanding is that the negative flow cross match is meant to be current, um, um, as opposed to historical cross matches. But I would lean on the HLA experts that are on the call to discuss that.
Yeah. Yeah, I see Ahmed's doing similar to what we do, which is to include the peak. I don't, it's not, there isn't data to suggest that that is a risk of memory sort of predictor, but I think it is. I personally think it's nice to have with my HLA brain, but yeah, I don't know that it's, I just asked because I think it's not the same everywhere, and I was curious what other people are doing.
Yeah, I mean, it's interesting because then I guess my question to you is what would you recommend if you had a negative, a mixed result? You had your current was
Yeah.
negative, but your
Oh, I mean, it
historical.
will be positive. The peak is most likely going to be positive. And so I guess maybe it's a matter of, collecting the data. So we see, is that a predictor of memory response? Is that a predictor of AMR? Like maybe it's actually useful to start collecting these data. We should, by the policy, I believe, go ahead because it's current negative. And we know we're crossing historic antibody. That's the nature of the program. But I'm just wondering if it's worth baking it into the policy to get a little bit more information about it. And maybe it will be a useful metric, in the future when we look at incidents of AMR or or AMR that doesn't respond or a more robust response. Would that have been useful information as to how strong it was? Anyway, that's just my thought. But thank you. It's a great talk today.
Thank you.
And then in closing, Sean, I think you posted in the chat to join us on Wednesday, October 29th, as we host another world-class great talk on survival of transplanted allogenic beta cells with no immunosuppression. But having said all of that, Dr. Mainra, thank you so much for a wonderful presentation and sharing all of your great work with us today. Sean, I'll turn it to you if you have any final words.
Nope, you get the final word. That was fantastic. Thank you so much, Rahul.
Thank you. Thanks, everyone.
Thanks, everybody.